Good evening, everyone, and thank you for joining us. Tonight is the third webcast in the 3-webcast series on keratoconus management. If you missed the previous 2 webinars and would like to see them, you can visit our website at www.oculususa.com, where we will have a recording posted within about a week following the live broadcast. I would like to point out that you have a text box on the right side of your screen for typing in questions. Feel free to submit questions during the presentation, and we will have a Q&A session with the experts at the end. On behalf of Oculus, I'd like to thank the International Keratoconus Academy of Eye Care Practitioners for making this all possible, and a special thanks to Dr. Barry Eiden, Dr. William Tullo, and tonight's speakers, Dr. Clark Chang and Dr. Andrew Morgenstern. It is an honor to have a group of such dedicated and knowledgeable doctors, and it's been an honor to work with them. And so without further delay, I would like to give the floor to tonight's first speaker, Dr. Clark Chang.
Thank you, Chris, for the wonderful intro, and thank you, everybody, for joining us tonight. It's the end of the summer. It's the end of your day. We know that it's tough, and we also thank you for your dedication of wanting to share your ideas and also come and hear us share our ideas. Both Andy and I tonight have a lot of material prepared for you, so I'm just going to get right into it. We're going to focus in this third series of the webinar on the webinar series on keratoconus management. Today we're going to focus more on some of the management modalities for keratoconus, and this is my disclosure slide. And you'll see that Andy's been getting a lot busier than I have, which should be the case. Andy is brilliant, and so obviously we can't forget about, in terms of management spectrum, we can't forget about what we do best, and that is optical rehabilitation, right? Regardless of whether it's pre-surgical, post-surgical, whether it's with spectacles versus contact lenses and specialty contact lenses, it's something that, and as well as just being the management point or the gatekeeper in terms of directing patients to different type of surgery should you feel like a specific surgical option is appropriate for your patient. And here is an illustration that I have taken from one of the recent publications that I enjoy reading, and it sort of gives you a simplified view of when different interventions comes into play for your patients, as well as going back to spectacle and contact lenses. So that's very briefly focused on contact lenses first, and that's going to be my part of the talk. And because again we want to get to surgical options, so it's just going to be a very brief general strategy in terms of contact lens management for keratoconus patients, as well as obviously spectacle management. We all know that obviously in terms of irregular corneal optics, the especially hallmark with most of the keratoconus patient in terms of that very asymmetrical corneal profile as represented here, where it's typically, not always, but typically, superior flattening versus inferior steepening in terms of your keratoconus patient, and that sort of sets up a situation where this asymmetry causes a lot of aberration differences surrounding the visual axis, which is typically why glasses known to mostly correct for your lower order aberration is not something that is a very effective treatment strategy. Unless we catch our patients early, of course, and I think obviously that we all know. And the main problem with, with spectacles is, as I've alluded, it manages most of the time your lower order aberration, right, your first and second order. And whereas the irregular corneal profile sets up a situation where that is no longer satisfies the visual needs of your patient, as can be measured by different clinical diagnostics that Dr. Morgenstern, as well as Dr. Tullo and Dr. Eiden had covered in series 1 and 2 in terms of keratoconus background. And we can see that using different clinical diagnostics that obviously in terms of these irregular cornea patients, that the source of their higher order aberration obviously is mostly from their cornea, and that is what we're aiming to manage, whether with contact lenses or surgical options. But not to underestimate that sometimes I think if you're only relying on reading color patterns of, maybe from a more traditional topography, that sometimes a somewhat irregular looking corneal profile distribution in an Excel map may actually give you surprising clinical outcomes when you actually take the time to refract your patient. And that is because there are times whether the irregularity is a little bit more central, which obviously sets up a situation where it's less irregular than the profile that I have shown you with the flattening on the superior and inferior steepening. But if the steepening inferiorly is very far away off the central area, and that therefore the irregularity somewhat spares the pupil, combined with the fact that patients, whether they're accommodating different light setting or just tend to have, maybe younger patients have smaller pupil, you can now see what an irregular cornea on the axial map now looks much more orthogonal. It's not exactly regular, but it looks much better combined with their pupil acting as a natural stop. And therefore, if you take the time to refract them, you actually find that sometimes there are patients who may be on paper is not somebody you think is an emerging or mild keratoconus, or in terms of corneal irregularity, can actually have somewhat of a good visual acuity after you refract them. So don't ever underestimate, obviously, taking the time to refract your patients. And that's obviously those rare chances spectacles can actually work. But the problem goes deeper than that in most of the patients that I see, and it's not just about higher order aberration, but even if they happen to be those fortunate one where with the example that I've given you before, we know that the definition for keratoconus is also that bilaterally they are typically very highly asymmetrical. So that obviously is going to set up an isometropia type of situation where in spectacles there can be a lot of issues with anisoconic symptoms. And even if we overcome all those barriers, you and I know that, with the experiences that we have with patient encounters time and time again, even if we get them to be a very happy place with spectacles, progression is the problem, right? Because 6 months later, depending on the age of the patient as well as the nature of their disease, they may actually not be happy 3 to 6 months later, and therefore sets off a situation where cost may become an issue and their compliance in terms of returning for follow-up, or in terms of their contact lens compliance may actually go down, because once you get them to a place where they're happy with whatever refractive correction tools you give them, if for some reason they get lucky and something can last much longer this time, they may actually not feel the need to want to purchase something else even if they need to. For example, that's why a lot of people put up with uncomfortable contact lenses. So we know progression is as well is the enemy in this type of situation with regard to our patient management. But coming back to what works best, as I've alluded with beyond spectacles, obviously we know contact lenses is still king, right? In terms of managing these irregular cornea patients, whether keratoconus or ectasia, and we have a lot of, especially in the last 5 years or so, we have a lot of growth in the contact lens technology sector. And therefore, there are lenses such as hybrid or scleral lenses that can overcome even the most irregular or most elevated type of corneal profile. And here's just a standard contact lens options that you and I are all very familiar with. But just for the sake of time, I want to actually propose a slightly different way of approaching contact lenses. So most people, if we go back to the list very quickly, tend to kind of separate soft lens for maybe early, possibly emerging keratoconus, mild keratoconus, and beyond a certain stage when spectacle and soft contact lenses kind of do not, for one reason or the other, not work anymore, we look into the specialty lenses, and that most of the time is going to be some sort of gas-permeable lenses. So we sort of have that separation of soft on one side and some sort of gas-permeable lens on the other side. I actually feel like a quicker approach in terms of matching your patient, especially in the day and age of what we have today, so many different variable designs of contact lenses, is to look at two things, two main things, and that is the amount of sagittal depth that is needed versus the amount of higher order aberration in your patient's symptom or what they're experiencing. And so by that I mean, if I feel like it's when I use, say, instruments like with a Scheimpflug image, where you can actually use that to get an assessment of how elevated, as in how deep the anterior chamber depth is. That gives you a sense from the apex going to the iris plane. That gives you a sense of how highly elevated that cornea is. So I like to look at the elevation and the amount of sagittal depth that is required from me to design a contact lens versus what kind of double vision, what kind of star bursting, what level and magnitude that patients are talking about, and certainly aberrometry can help. And Pentacam also actually gives you an assessment of higher order aberration. You can look at a Zernike distribution as well, but that's one way that I would like to use this type of diagnostic instruments in terms of looking at the sagittal depth that is needed. And I think we can all appreciate the fact that the first one is a lot deeper. And I'm sorry, this is a patient who actually did it over a contact lens, so just in case you wonder what that extra the extra curve is in front of the cornea, that's actually a hybrid lens being fitted over a keratoconus that had a Kmax of 99 point, I can't remember, I think it's 99.6 per Pentacam, versus that kind of sagittal depth versus this one right here. And you can actually drop a caliper there that gives you an actual micron value. I just find that by looking at, I like to I like to visualize and get a sense of, am I dealing with something that's a shallow or sort of medium or highly elevated sagittal depth corneal profile. So that's usually how I use this for. Or another way of, like I said, another way would be looking at the higher order aberration that is experienced by your patient, and outside of subjective complaints from your patient and how they behave with their glasses, another way would obviously be looking for you to use would be looking at their the curvature distribution of their anterior cornea, and that would give you a sense of the amount of irregularity that is present. And such as, this is a table that I've adopted from a very good colleague of mine, Dr. Greg Denaire, who wrote an article on a similar concept of matching keratoconus patients with different type of contact lenses. So, you know, one can also look at the different amount of irregularity that is present. Of course, it's more of a clinician's subjective interpretation in terms of what kind of irregularity and how much is present. But it's certainly helpful to have a more precise instrumentation. I think we can all agree that if you look at, even though both of these corneal profiles have pretty similar has pretty similar max K, according to roughly about anywhere from in sort of the 52, 53 diopter range, you would fit a lens very differently when it's more of a central type, that's called a nipple cone, versus someone with more of a pellucid type of pattern who actually turns out to be keratoconus. So we can all agree that different contact lenses will be required, simply because if you look at the curvature on the backside of the contact lens, the maximum area with the deepest sagittal depth is going to be at the center of your contact lens, correct? So that is the reason why anyone with more centralized irregularity is going to be much easier to fit with all different types of contact lenses, versus if you have someone whose highly elevated area is in more towards the mid-periphery or periphery, where the lens actually is decreasing in the amount of sagittal depth that is created by a contact lens, you're now obviously going to be much more limited with the design that you can apply to this cornea, as well as you're going to need to raise the overall sagittal depth that is required. So those are the two ways that I look at different ways of separating what type of contact lenses may be needed and how I can utilize the instrumentations I have in clinic in coming up with an assessment plan of what I want to do with my patients when they come in for contact lens fitting. And also, being that I worked at a refractive center as well, don't forget that, we see refractive patients after refractive surgery very often, and I actually didn't tell you that with the very first example that I gave you here, when I have more of a sort of centralized nipple cone appearance, that's actually a patient post-hyperopic LASIK. So if you have, let's say, and we encounter those patients a lot in terms of post-refractive surgery, and if you have a patient who come in and you're wondering, they're complaining of some visual issue, is it some sort of progression? Because, patients don't know if they are seeing starbursting or halo or ghosting. They have no idea what they're seeing. They just know they're not seeing well. And let's say you have somebody who has vague complaints of vision issues after refractive surgery, and you're wondering if it's possibly a situation of ectasia. Well, that is going to be difficult to determine if you don't look at the elevation changes, especially on the posterior side. So if you look at this, even though you're looking at centralized elevation centrally, and if this patient comes in complaining of, say, in the last year or so, vision is decreasing, you can take a look and say, well, the elevation on the back right now is not changing. Obviously, you can, if you have access to aberrometry, you can combine with that in terms of coming up with an assessment plan of saying whether or not this is an ectasia in development, or is it just somebody who potentially maybe have some lenticular changes or maybe dry eye. I think this kind of instrument, when used creatively, can actually really help you with that situation. But overall, just to finish off on the contact lens side, not only do we want to fit the contact lens to the patient, rather than forcing patient to say, I only fit corneal GP and that's all that I'm going to fit. If we can, pay attention to a general approach in terms of the amount of higher order aberration that they experience and what kind of corneal profile, feel free to use the Scheimpflug technology to get a cross-section if that helps you. OCT can do similar things as well. But let's not forget that long-term health, I've talked about compliance issue. Long-term health is what's going to set us apart in being able to provide good service to our patient across their entire life. So if we look at a CLEC study, we know that, and again, just focusing on briefly talking about corneal GP, because that's still a pretty common type of, so sort of the gold standard lens for irregular cornea, even though I think that's slowly going to change with hybrid lenses and scleral lenses being available. But if you look at the CLEC study, a huge majority of patients entering baseline is wearing rigid gas permeable lenses or corneal GP. And by the end of the study, 8 years, with a little over 1,200 patients, I think 1,209, you can see that about corneal scar can be observed in 31% of patients who came in wearing lens fitting appearance that is classified as fitting as flat or apical touch, whereas only 9% of scar, only 9% of those have observance of corneal scar when they're fit in a steep or apical clearance. So that gives you a sense of, even though, because it's not a prospective and randomized study, it's not able to actually statistically give you definitively say what's the causative factor for the corneal scar, but it certainly tells you that the association with regard to corneal scarring is very high with someone who we are maybe unintentionally causing epithelial trauma. So what that means is something that would help us in long-term management would be watching for epithelial health as well as endothelial health. Obviously, high DK value in terms of the material we use is very important. But also, I want to use the case to highlight a good understanding of what keratoconus disease is, how that can be applied, how a good working definition can be applied to your contact lens management. So this is a young patient, I believe about 26 years old, white male, who came in having been fitted with a corneal GP for the past 3-4 years or so. Sees pretty well. This is the worst eye. Has reported a history of corneal scar, and being that I was in a cross-linking site as a study, we were not able to treat an eye with corneal scar, so we cross-linked the other eye. But meanwhile, as he's recovering from cross-linking, which Dr. Morgenstern is going to talk about momentarily, meanwhile as he's recovering, I was given the job to try to find a better option for him for the untreated eye in terms of giving him usable vision. He's about 20/40 with a central scar that was documented in his history. And if you look at the sodium fluorescein, you think, oh yeah, corneal scarring, right? And that sort of explains why he's only 20/40 plus 20/30 minus-ish. Except when I look at the actual, if you look at the lower left-hand side, when I took the lens off, and again, still central scarring, almost sparing the very center of the pupil, but not quite, which again explains why he's 20/40. But if you look at those deep stromal neovascularization and the fact that there's a center sort of bullseye pattern in his scarring that looks very white and creamy, which is very unlike a fibroblastic proliferation type of scarring situation. And the fact that if you flip open any textbook, you see keratoconus is a disease that is non-inflammatory as well as non-vascularized. Now we can argue about non-inflammatory, but non-vascularization is a big, at least our current working understanding, is a factor in terms of diagnosing keratoconus. So looking at those blood vessels and actually where the end of the blood vessel is where that area of corneal scar, quote unquote, is being diagnosed, I thought, and looking at the optic section, I'm not quite convinced that it's a corneal scar. I actually think it's lipid keratopathy and leakage from blood vessel. So after I refit him into, because he was looking for a more comfortable lens option, I refit him into a piggyback for a while. And then I just want to prove that it works prior to putting him in a scleral lens, and you can see that about a year later with 6 months in piggyback and 6 months in scleral lens, that the area of neovascularization regressed, as well as that area of supposed scar tissue has also started to fade into the point where he actually is reaching 20/20 minus or 20/25 plus visual acuity. So that is something that we need to be concerned about in terms of knowing the definition of keratoconus, as well as what instrumentation can we use clinically to monitor corneal health. Ultimately, if we are able to, the best way will obviously be not to have to wait until somebody is a patient with keratoconus is in a severe stage before trying to come up with some other medical management options to potentially, say, halt their progression. And obviously one thing would be cross-linking. And if you look at this paper that was published in 2015, don't underestimate the number of times, if you look at the number of times they actually mention contact lenses or glasses after each surgical option, you can see that we ultimately carry the most important role here. After sending patients into receiving any type of surgical intervention, ultimately we have to functionally rehabilitate these patients most of the time with glasses. I'm sorry, most of the time with contact lenses. And you know, certainly our job is made easier if we can utilize newer surgical technologies such as cross-linking to be able to stabilize our patients so that whatever options we come up for our patient can last as long as possible. So that obviously is going to lead us into cross-linking and other surgical options. And I'm going to bring up my good buddy, Dr. Morgenstern, as he's the world-renowned expert in this area. So, Dr. Morgenstern.
All right, Clark, that was fantastic information. I just want to say thank you to Chris and Oculus. You know, these presentations couldn't go on without it. And this is a perfect example of, you know, clinic working with industry together, supporting each other to benefit the doc, which translates right down to the patient, and that's what we're looking for. So, Chris, thank you very much, and Oculus, thank you very, very much. And, you know, I'm really lucky. I get to work with 3, and obviously more than that sometimes, but on a very regular basis, 3 of the best partners that I can ask for in our International Keratoconus Academy, Bill Tullo being one of them, Barry Eiden being the second, and Clark Chang. And we have other board members as well, like Joe Barr and Tim McMahon and Dr. Eric Donenfeld and Yaron Rabinowitz. But with Bill and Barry and Clark and I, we work together on a really frequent basis, and I can't tell you how much fun it is because all of us have a really deep passion for the solutions related to refractive error, refractive disease, cornea and external disease, and this is just a whole lot of fun. And you know, Clark, being the young gun of the bunch, I would definitely have to say, you know, behind closed doors, we get a little scared of Clark because he is so smart and challenges us so heavily, and he is an incredible mind that is going to be in our profession for years and years to come. So, Clark, thank you very much for the great introduction, and thank you for all the information and all the knowledge that you bring to our organization.
Thank you, Andy. By the way, he's only saying this because he knows he's being recorded.
We're absolutely going to come back at some point in time, and the guy owes me money, so I got to get it out of him. So.
There you go.
Excellent. That, he's driving the slide, so I'm going to ask Clark to go to the next slide, if that's okay. I got to be nice to him.
Of course.
So really, you know, one of the biggest things that's one of the most important things that we have to consider as eye care professionals is that, you know, everybody knows that keratoconus, you know, is a very common disease, but the amount of the way that both optometrists and ophthalmologists see this disease presented in their practice is very interesting because, you know, when I was at seeing refractive surgery patients all day long, I would see these patients come in. I would identify a keratoconic patient probably in 1 out of every 50 patients that presented to my clinic, 1 out of every 50 patients that presented to my clinic. There's a reason for that. Number one, we all know that, you know, patients that present to a refractive surgery clinic typically can't see well and they want to get a problem fixed. But number two, you know, we have to, as refractive surgery clinicians, I would say more than anybody else out there, because we have a really, we have something great to lose, and that is the patient's vision if we don't identify this disease. We have to identify this disease. There's no such thing as letting a true positive slip through the cracks. We would rather very much err on the side of identifying false positives than letting a true positive slip through the cracks. So we need the right equipment. And really, fundamentally, that's what this is all about. And what I mean by that is if we don't have it, we can't identify it. When using the right equipment, like a Pentacam, which is my, and I'm not saying this because this is run by Oculus, I'm saying this because I have almost 2 decades of experience in refractive surgery, and this is the best device that I have available to me to identify these keratoconic eyes at its earliest stage. And the question becomes is, if we were all to use a device like this, assuming that what I believe is true, and that this is the best device to identify early keratoconus, because it does give us a wonderful view of the cornea in many different ways. what is the true prevalence of the disease in the United States? What is the true prevalence of keratoconus in the United States today? And in the past, like the slide prior to this one said, and Clark, you do not have to go back. There you go. It was about 1 in 2,000 based on information that was presented by one of our board members, Yaron Rabinowitz, back in 1998. Problem in 1998, we didn't have posterior elevation measurements, and we didn't have great analysis of pachymetric distribution of the entire cornea. And now that we do, there's a lot of folks, a tremendous amount of folks that are estimating this disease, the prevalence to be somewhere in the neighborhood of 1 in 500 to 1 in 750. Well, guess what, folks? That means that these patients are coming in and sitting in your chair right in front of you, and in some cases you're not identifying it. Primarily for the reason, like Clark was showing us before in that great 4-map Penacam, where he overlaid an iris onto these maps. When we're using, let's say, a keratometer, we're only looking at the central 3 millimeters of the cornea. If you put up that picture again, which you don't have to, Clark, if you were looking at the central 3 millimeters of that map, like Clark said, that patient would have been completely orthogonal. You would not have seen tremendous distortion on your Myers on keratometry, and those patients can ultimately slip through the cracks, especially if they're young and their disease is not that obvious yet. So we have to be on the lookout for this because it is out there. One of the big, and we can go to the next slide, Clark. Thanks. So enhancing keratoconus management through interventional options. We know what this disease is. It's a bilateral asymmetric disease that affects visual acuity, potentially can end up in an operating room because the tissue may have to be replaced by cadaver tissue or synthetic tissue that is essentially an artificial cornea that we hope doesn't have to be used in these patients. But the goal here would be to, if I had a perfect world, we want to identify this disease as early as humanly possible and arrest the progression of the disease so it does not become a transplant. Any cornea doc, really, the whole goal of cross-linking, jokingly, is to put the cornea transplant surgeons out of business. And it's a pretty challenging statement to make, but if we could take this disease and arrest it at its earliest age and not make it progress so they don't need corneal transplants, you're going to have visually much happier patients for the rest of their life. You also want to create a more prolate cornea, and like Clark showed you in that wireframe chart from the cornea study from Gomez et al., every one of these cases of keratoconus, it doesn't matter what road that they go down, whether they progress onto surgical treatment or not, ends up in our chair for contact lens management. So we want to have the easiest fit possible. We would like to, if we can toss softballs into those exam rooms for us to fit, that's the best thing to do. And identification of these patients early and treatment of these patients early with cross-linking is really our best option that we have in 2016 right now. Next slide. So the biggest question I get, and for optometrists that are on this call, I'm going to apply this to something else. So isn't there anything you could do to stop this from getting worse? Well, if you are an orthokeratology optometrist that works with myopia control, you're facing this problem as well. You're just not thinking about it in terms of keratoconus. You're thinking about it in terms of myopia. Parents come in every single day to every one of our practices around the world and ask us, is my kid's vision getting worse? Is it getting worse? The answer, yes. Okay, what do you want to do? Let's give them stronger glasses. That's really not an acceptable option anymore because we know so much about myopia control, and there's many optometrists on that call that get it, that makes sense. We know that we can use either atropine or hard contact lenses or soft contact lenses in a specific type of pattern to stop this from getting worse. Well, the same concept applies to keratoconus. Patient comes in, we check them out, we do mapping on them, we check their vision, we look at their Ks. Is it getting worse? Yes. Okay, let's refit your contact lens and just watch it get worse. No, that's not the right answer. The right answer is let's put the brakes on. Let's stop this from getting worse so the patient doesn't have to deal with the sequelae of progressive disease for the rest of their life. Because every one of us on this call know that there's no disease that gets better by doing nothing about it. there's nothing out there that really that happens with. So we have a procedure called collagen cross-linking. And really, this slide, it has my name on it, and I wish it didn't right now because I want to make sure, and this one slipped through the cracks on me, because really what we want to call this procedure now is corneal cross-linking. And the reason why I say that, and cross-linking is even a bad word. Initially, when Clark and I really, back in I would say, the late 2000s, maybe around 2009, 2010, when we were getting all, starting to learn the big stuff about cross-linking, early on we actually thought, and the populace of researchers thought, that we actually created stronger bonds between the collagen fibers and the cornea, but today we know that's not the case. We actually strengthen the tissue that's existing there. We don't necessarily create bonds like rungs on a stair ladder. That we once did. So it's a strengthening procedure. Really, it's not cross-linking any collagen. It's actually strengthening the corneal collagen tissue. Next slide. Excellent. So one of the things I did today, and I pulled this today just to show you. Some people said, I just noticed on the third reference down, I didn't see it before, that there is a C. Chang referenced as the third author, and I'm sure that is not our good friend Clark Chang.
This one's not me, no.
No, I know it's not your middle initial, so but you should take credit for it. So I went on to Pubmed just to see, collagen cross-linking, which is the terms that everybody uses. How popular is this, and how much literature is published on this thing? Just to give a frame of reference. So as of today on Pubmed, there were for the header of collagen cross-linking, there were about 4,400, not about exactly, 4,431 collagen cross-linking articles. There were another 1,100 that were corneal cross-linking articles. And just to put this in perspective, if I put into that header topics like keratoconus and LASIK, how many hits would come back on the researcher there? Well, take a look at this. 4,400 on corneal collagen cross-linking. There's only about 1,000 more on keratoconus. The entire disease of keratoconus. If we go to the next slide, just looking at LASIK, you can see there's just about, still, again, only 1,000 more articles published on this. So to give you a frame of reference, this is an incredibly researched topic. And there is a ton of research out there. This is nothing new. It is now FDA approved, and we're going to talk about that very soon. And this is something that we just have to be aware of. Next slide. So here's the history. This really started trickling through the FDA in late 2011. The company called Avedro, which is the one who got FDA approval for it, based out of Waltham, Massachusetts. A wonderful optometrist, one of our good friends, Grace Lytle, heads up the professional relations department over there. I know she's a graduate of the New England College of Optometry, and she's done amazing stuff for us. Clark and I use her as a resource all the time, and Grace is making optometry and all of eye care proud by the great job that she's doing. Next slide. So this all started 2011 when it was submitted. In March 2014, Avedro received a letter from the FDA requesting more information on the products that they submitted. Next slide. And then in February 2015, the FDA, DODAC, the Dermatologic and Ophthalmic Drug Advisory Committee, voted in support. So this is basically a pre-vote for FDA. Next slide. And they said, yeah, this seems pretty good. And then when it went to actual vote, it voted as 10-4 in support of approval for progressive keratoconus with one abstention, and 6-4 in support of approval for corneal ectasia following refractive surgery with 4 abstentions and 1 member not voting. So this is the pre-vote. It went down that year in 2015. They resubmitted for a new drug act, part of the PDUFA, Prescription Drug User Fee Act. And next slide. Ultimately, in April 15th of 2016, this past year, Avedro's corneal cross-linking procedure, 2 things were approved, just to be perfectly clear. Number 1, the device was approved in an epi-off fashion, which means the epithelium has to come off the cornea to apply the riboflavin. The riboflavin as a photosensitizer was viewed as a drug called Vibex, and that actually had to be approved separately. So both the riboflavin formulation as a drug and the device as used for epi-off cross-linking was approved on April 15th, 2016 of this year. And Clark and I were doing cartwheels down the hallway when that happened, because we know how important this is to the population and really how much it could help people. And the United States, just to give you, again, another frame of reference, the United States was the only developed country in the world that did not approve corneal cross-linking for the treatment and management of keratoconus. Everywhere else in the world, the entire European Union had approved this by 2006. So we're a complete decade behind them. So essentially what's going on here, we're using UV light and riboflavin being the photosensitizer, and that's where the critical mass happens to strengthen the tissue in the corneal collagen. It halts progression and irregular changes in the corneal shape known as ectasia. And next slide. Just to give you some results, here's the Theuring study. And so people, you know, always, the question that I would have gotten in clinic years ago, and not anymore, but, you know, how much information do you have? You know, we know this has only been approved since 2006, since April of this year, only a couple of months. How much information do you really have? So here's one of many studies, the Theuring study, which has 10 years of data. Next slide. There we go. And you can see the parameters here, 28 years old. The range was 14 to 42 years. 4 patients were female, 7 eyes. 16 patients, 23 eyes were male. You can see the Ks that were looked at, the Kmax and the Kmin. Next slide. These are classic keratoconus patients over here. And some of the results were neither the corneal endothelium nor deeper structures suffered any damage. Only 2 of 20 patients had continuous progression of keratoconus and needed a reapplication of cross-linking, and that could happen. Remember, you know, what we're doing right now, we're in the earliest phases of the treatment of this disease with this procedure. Right now, we don't have very good methods to give personalized treatments of keratoconus. And, you know, just like any other disease, there's going to be varying severity levels of the disease that are going to require varying levels of treatment. And if we're giving one basic treatment to the entire population, there's going to be patients that fall outside the bell curve and require more treatment. There are some infections that need more medicine. There are some cancers that need more chemotherapy. There are some patients that have HIV that need a different cocktail. And so it makes sense that not every patient is going to respond the exact same way, because as we all know, not every keratoconus, and quite frankly, every keratoconus patient presents differently to your practice. And like Clark was talking about, all the varying types of contact lenses that we have available to us in our tool belt could be used on a wide variety of different patients. Next slide.
Sure. And Andy, if I may just quickly say something about this study. Since you specifically mentioned the K value that was summarized in the results section from the study, I just want people out there to understand, because you and I get asked this a lot, and that is, well, what range of keratometry value in terms of their keratoconus patients should they start thinking about referring for cross-linking? And I just want to say we have to remember a lot of these early studies have to, you know, they're not aiming to define the candidacy of cross-linking. So we're not looking at these K values to say, oh, well, if you have, you know, about 50, you have pretty good effect, and then, you know, sort of like, you know, there were papers on Intex before where they thought 55 diopter may be the limit, and there's no more benefit after if your steep K is steeper than 55 diopter. So I want to make sure that we don't look at these values as such. And in fact, Peter Hirsch, Dr. Hirsch, who I worked with for many years, we published a paper in showing that at least in our study, and our data was part of the Avidro data, in fact, those who had steeper Ks actually had more flattening. They had more robust response to cross-linking, especially with keratoconus versus ectasia. So I just want to make sure that people don't look at those as hard values to use in terms of thinking about who to refer for cross-linking.
Well, you bring up an excellent point, and you know, we can go through all these slides right now, but at the end of the day, I want the docs on this call to take away something from this. And so I'll ask you the question, Clark. Who do you refer for cross-linking? You know, when a doc is sitting in the room and there's a patient sitting in the chair, they've got to, you know, the hardest part about doctoring, I think, is, you know, identifying where to draw that line in the sand and make a judgment call on to treat or not treat or refer or not refer. So when do you refer for cross-linking? How bad does your patient have to be? And what age do they have to be? Let me throw that one out to you.
Sure. I mean, that's an interesting question, obviously. And again, if you look at a lot of the early studies, they take these progressive keratoconus, typically with a certain amount of severity, before they would enroll the patient. Not too severe because they weren't sure if that's going to interfere with their outcome and throw in confounding variables that they weren't expecting. So you're typically looking at these sort of moderate to early severe patients who are enrolled in these early studies, and if you read a lot of these long-term studies, that's sort of the group of patients they were pulling from. But ultimately, everybody knows, once they saw how promising the results were, that the people who will really benefit from this type of treatment are really the people who weren't exactly included early on, and that is the young patients who we know to have these, statistically, they are very likely to be very progressive, very aggressive in terms of the type of disease that they have versus someone who's diagnosed much later. So really the type of patients who would be ideal for these, for a cross-linking procedure would be those pediatric patients who hopefully with emerging maybe mild amount of keratoconus were caught early, and where we could really be doing them a huge favor across their lifetime to save their vision and also make it easier to fit them in contact lenses and glasses, and also our diagnostic instrumentation are much more accurate on a cornea that is not extremely irregular. So all around, those are the patients who, making our job easier, but those are the patients who really we should be thinking about referring for cross-linking.
Yeah, that's totally agree. Let me ask you two other quickie follow-ups to that. You know, do Ks matter, right? Do you have to have over a 50K to refer in for cross-linking? Can I send in a patient with a 46K, a 45K that I think has really minor changes of keratoconus? That's number one. And number two, what's the minimum age?
Well, let's answer the minimum age right now in U.S. because that's an easier question, and that is 14. At least for the FDA approval cross-linking, you can look for some other study sites that I believe will have lower age bracket.
Right.
But for FDA-approved cross-linking, we're looking at 14 and older.
Right, for FDA approved, but I do know that we treated a 5.5-year-old and we treated plenty of patients under 10-year-olds,
right.
10 years old in our center. It is off-label, you have to make the patient aware of that, but the treatment's no different. And I think the Gomez study said that there's really no age max or age min when considering treatment. And then, do you have to, let me ask you, forget the exact number, but do you have to have a specific K value to refer a patient for cross-linking?
Right. Well, I mean, definitely not for ectasia. Let's be frank that it may be a separate type of disease versus keratoconus.
Right.
But for keratoconus-wise, no, because if you look at, and let's go even with the paper that you had just mentioned with the Gomez et al. Group, their definition, for everybody out there, it's the global consensus paper on keratoconus and ectasia management that was published in 2015 that we had referred to earlier. Their definition for keratoconus, which I know is going to come up a little bit later in the slides, actually doesn't include keratometry value. And so therefore, no, I don't believe that you need to look at keratometry value. However, I mean, obviously, if you're diagnosing somebody with 41 diopter as the Kmax with keratoconus, you need to have a look at other factors. Obviously, that's going to be very rare, but you need to have a look at other factors like pachymetry rate of changes and things like that to be able to say whether or not ectatic disease is present.
Got it. And the last question, because I know we're actually running a little bit low on time, but I do want to ask you this question, because I get it all the time. When Clark and I lecture a lot together on this topic at all around the globe, actually. And so the big question that optometrists ask me specifically, and this is addressed to the optometrists that are on the line. I'm sure there's a couple of ophthalmologists and other eye care providers, but the OD question I get is, can I do this? Number one, and I'm going to answer that a little bit, and I want to see if Clark will agree with me. Can I do this? And then, but the follow-up question is never there, and that is, what do I need to do this? So a lot of optometry, can an optometrist do cross-linking? Well, my answer to that is it depends on what state you live in the United States, because every, laws for optometrists are different in different states, and it is not my business or place or Clark's or Oculus's or anybody else to go outside of the bounds of referring you to your own state laws. But I will say, for the optometrists that are asking, can I do this? The answer is, I'm sure you can if your state laws are okay, but you can't do it unless you have the right equipment to measure and monitor these patients prior to the procedure to make sure that they're progressing, and then afterwards, how do you monitor them to see that they're stable? So, Clark, I'll ask you this: what's the minimum stuff that you need, and what are you looking for? And the two go together? Do you know what I mean?
Yes, absolutely.
So, what are you looking for, and what do you need to do it?
Right. So, again, so that it all comes back to, in any studies, you never want to have false, as much as you don't want false negative, you don't want false positive, right? You don't want to treat somebody with cross-linking thinking they have keratoconus, and they end up just having, say, a displaced apex or other type of disease that may look like they have keratoconus and therefore give false outcome. And that's actually why a lot of Cochrane had done like has done a review on most of the study out there and say, there are just so many confounding factors in monitoring a lot of these studies with regard to keratoconus. If we're getting, a lot of, which is why you have that global consensus paper in trying to set up a good working definition of what keratoconus is, because our rate of success is ultimately depending upon whether or not we're diagnosing correctly. And we used to take this for granted because number one, we thought it was very easy to just look at colors, look at the, on a topography, on a traditional topography, look at the red, the warm area inferiorly, we say, bingo, that is either pellucid or that's keratoconus, and that's actually not true, whereas the newer definition, even if we don't look at biomechanics, it at the very minimum, includes abnormal posterior elevation. Therefore, you need equipment beyond just looking at topography. So an example would be obviously using and it's not just because Oculus is sponsoring this talk.
Right.
It's because if you look at all the studies, most of them out there, including the FDA study, the FDA data that was submitted by Avidro, all the study group actually uses a pentacam because not only can it act as a topographer, it also has a tomography function of monitoring the elevation changes both on the posterior cornea and the anterior cornea. And that is included right now in the working definition of what is minimally required to define and diagnose a keratoconus patient. So first and very foremost, at the very minimum, you need an instrument like that to allow you to diagnose as well as monitor patients in terms of whether or not they may, for example, are they progressing or do they need retreatment should cross-linking in the rare cases actually quote-unquote wear off. And so I would think that a minimum instrument for me would be something that's comparable to the Scheinflug image technology that the Pentacam has.
Got it. And can you just advance through the slides, because we're pretty much almost out of time right now, and just get to that one slide where the Gomez study, which is the cornea study, the global consensus study, has the 3 minimum parameters of what it takes to diagnose. Clark and I, we actually, I can't tell you how many hours we spent on the phone trying to cut these slides down from like 400 down to 70. And
this is the progression one.
Right.
Is it after this, Andy?
I believe it is. Well, basically, what we're looking for, the global consensus study on ectasia. So basically, all the major cornea societies from around the world, Eucornea, Pancornea, the Cornea Society, and I forgot what the last one is. It's basically Asia, Latin America, Europe, and the United States.
And Asia, yeah.
Yep, and so basically, and the United States, yep. And they got together, experts, cornea specialists, keratoconus experts from all the major cornea societies got together and basically figured out and made a working definition of what it takes, what is keratoconus, what is ectasia, what does it take to diagnose it, how do you monitor it, and how do you treat it afterwards. And that's the global consensus study. It was in cornea from the American Academy of Ophthalmology in April 2015. And basically what they came up with, number one is to diagnose these, there it is, diagnose these patients, and here it is, that's the slide we're looking for, as early as possible. The young patients are the ones you want to watch out for, and the mandatory findings that they came together to diagnose keratoconus, and this is the peer-reviewed evidence. This is nothing that any of us can really challenge too strongly because it's such a strong consensus paper. You have to have an abnormal posterior ectasia. That means it's a camera that looks at the back side of the cornea to see if it's bulging forward. An abnormal cornea thickness distribution. That means you have to look at a global pachymetry of the cornea to see how much from the center out to the periphery that change is taking place, and is it happening at an irregular, non-consistent rate. And then you have to have, as Clark was talking about before, clinical non-inflammatory corneal thinning, and obviously not vascularized as well, as his slide showed. And if you look at this definition, there is zero bullets here that talk about getting an anterior surface curvature measurement of the eye to diagnose keratoconus. And that device is called the placido disc corneal topographer. That does not make up the working definition of diagnosing keratoconus anymore, and that's the big issue. And so I think it's really important to kind of digest this paper. If it was up to me, and I'm not on faculty, at least full-time, maybe as an adjunct at some colleges of optometry, but this is the kind of information that needs to go out to optometry students. At least they're in their second to third year, so they understand this, because almost every single optometry school has a Pennicam now that I know of, and they need to know what they're looking at at the cornea. So I'm going to, Clark, I don't know if you want to add anything else. I know we're right at 9 o'clock, and I don't want to hold anybody up here, but do you have anything else that you want to add as it relates to the cornea, to the global consensus paper? Because I really think it really made a pretty significant change in our line of thinking, or it really defined what we knew already, actually.
I agree, and I think just maybe two more things, and to follow up with what you said about nowhere does it mention curvature or keratometry in terms of diagnosing keratoconus. Nowhere, and so to follow up with that, also nowhere does it point to one specific reading in terms of pachymetry, such as what we always used to want to rely on, and that is, what is the CCT, what is the central, corneal thickness, because we always correlate that one absolute value rather than the distribution or the global pachymetry map that such as, Pentacam can do. We sort of always want to just have one value and use that to diagnose keratoconus, which obviously would be fantastic if that will work, but that actually have been found to be the least reliable indicator for keratoconus in the consensus paper. So I think that's one. And two, just to kind of finish up on, we were on the topic of what kind of instrument would you minimally need. So not only do we need an instrument that can diagnose properly this disease, we also need one that can, if you're on the camp where you feel like, okay, I really want to be very conservative, and I, for some reason, really want to wait until some major progression has occurred before I'm willing to refer for other type of intervention, then we need to have a good instrument that can monitor progression. So if you look at the progression definition from this paper, it then requires progressive steepening of the anterior surface, but also progressive steepening of the posterior surface. So again, you have to look at posterior, have an instrument. If you want to monitoring, you need to have an instrument that can look at more than just one layer in terms of the shape of the cornea, and as well as the change in the rate of pachymetry distribution. And that's, again, all all that you get with one instrument if you have that in clinic, and that would be the Pentacam. So for me, even though I think you need, it'd be nice to have other instruments, but if I have to choose one, this is the one that I really need for what I need to do every day for my patients. And those are the 2 points that I want to leave everybody with.
Yeah, it's funny because we were discussing all this stuff a while back, and it was funny because Oculus came up to us and said, guys, you're kind of screaming the message out that we're trying to advertise every single day, and this is what you're talking about. And I think that's why they selected us as speakers, is because we use it. I will tell you that Clark is currently a TLC employee. I worked for TLC for many, many years. They're the largest provider of laser vision correction services in the United States. And I will tell you that every single TLC laser vision correction center, really it couldn't actually work without a Pentacam in their office or some sort of Scheimpflug device looking at the posterior side of the cornea. Obviously it doesn't have to be a Pentacam. I'm sure Chris from Oculus would love us to say it has to be a Pentacam, but I can't say that.
But it doesn't have to be. That's correct.
Right, exactly. That's exactly right. But you do have to look at the posterior side of the cornea. And so at the end of the day, I think I would, if I was going to put a last bit of information out there, this is the most important thing that I want everybody on this call to understand, and that is that we have to screen kids as soon as possible for this disease. The earlier that we can identify it, the better visual life that they are going to have if we can get them treated with cross-linking early, if they fit the criteria for a progressive keratocone that can have corneal cross-linking. That is the best thing that you can do for these patients. And I will tell you that over the course of my career, I've seen tens of thousands of patients, just like many of you on the phone. In that time, I have identified 2 pediatric glaucoma patients in my entire career, and I've screened every single kid with an IOP measurement and looked at their nerve, and I have identified hundreds, if not thousands, pediatric keratoconus patients accidentally in some cases, just because I've been popping off Pentacams on them or other tests like that. The disease is way more common, and we have to have a logical approach to screening our pediatric patients because this disease is way too common. It's more common than we think it is. Clark and I are trying to figure out a way to screen this stuff and come up with a prevalence for pediatric keratoconus somehow, so we can get a good understanding, so the populace can get a good understanding. But screen your kids, screen them aggressively for keratoconus. It's more common than you think it is. Clark, do you have any closing words? And thank you to Oculus. And also, please visit us at the International Keratoconus Academy of Eye Care Professionals. It's keratoconusacademy.com is the website, info Keratoconus Academy. We have tons of information out there, free for everybody to grab. You can become a member for free for this year. And going forward, I believe, for the time being, we're not charging anybody because we want that information to get out. And thanks, Oculus, for letting us put this on. Clark, do you have any closing words?
Just that we'll also be doing an IKA talk in Vision Expo West for those who are going to be in attendance, and also in the Academy. So we'd love to see you there. Come up and say hi, and we'd love to discuss and share ideas with you.
Absolutely. So with that, Clark, I just want to thank you as well, and Chris, thank you for giving us the podium tonight. You put way too much trust and faith in us.
No, thank you guys. No, thank you very much, Dr. Chang, Dr. Morgenstern. Great presentations, and really for this whole keratoconus management series, I don't think the presentations could have gone better, and it's been great to have you guys on tonight as speakers. So with that, we do have a couple questions if you have time. There's not a ton on here, but some good questions if you want to field those. So
I'm going to have to take up the garbage with the recycling if I get done too soon, so let's take as many questions.
Okay, so then you're on for a few minutes then. Okay. One's a 2-part question, and I think part of the question has been addressed quite a bit, but I'll ask it here. When do you decide to initiate cross-linking, and is there any negative side effects?
So I think Clark answered his part. I'll answer my part. This is Andy, and the answer to me is I personally don't think there is an age too young. So any evidence of progressive corneal ectasia, possibly that being keratoconus or pellucid marginal degeneration, warrants significant and rigid and frequent follow-up to diagnose and see if there is any progression of the disease. And that, you have to remember, that's one of the things that we're looking for. You know, a keratocone that's not getting worse is not a keratocone that should be in the cross-linking chair. And there's a caveat to that as well, though. So if we have a patient that is, you know, 15 years old who is 20/25, the Ks are the same, the vision's the same, the posterior float is the same, the pachymetric distribution's the same, nothing is getting worse, I don't know what cross-linking can do to help that patient. So we do like to document progression. Now, by the nature of the disease and by the definition of the disease of keratoconus, it is progressive. So here's the struggle that I have, and I'll throw a question back at the question. Let's say I have a patient who has identifiable keratoconus in the right eye, vision's getting a little bit worse, cornea is getting a little bit thinner, the corneal indice, the pachymetric indices are changing, the best corrected vision's decreasing. That eye clearly needs to get, and the patient's, you know, 18 years old, 15 years old, whatever, that eye needs to get cross-linked. But what happens if the other eye is 20/20 and still saying 20/20? That's the eye that I struggle with, and I will tell you that I pay particular attention to which is the dominant eye, because if a patient's 20/20 and definitively has keratoconus, and especially if they have a genetic family member that has keratoconus, I have a hard time not treating that eye and stopping it from getting worse. There are risks, obviously, like you talked about with epi-off. I would say that corneal haze and possible corneal infection are probably two of the more common and only complications that I've seen in my career out of thousands of patients. But that to me is the hard question. Clark, what would you say about that? Do you treat the 20/20 eye of a keratocone when the other eye is progressing?
Right. You know, the easy answer, at least in terms of when we're doing it as a study, is that we always treat the worst eye first, right? And it's very easy for the patient and let's assume these are young patients who need to give their assent and then still have their guardian give their consent, would then be, hey, if you did really well, recover with no issue very quickly, you know, it went beyond your imagination for the worst eye, then it's very easy for them to actually want to personally request to have their 20/20 eye being treated as well. And so for me, really, I separate MDs and ODs into, and so we don't very often do bilateral treatment, number one, in the site that I was at. But I typically separate MDs and ODs into two camps, right? So those who are extremely conservative, potentially maybe due to the fact that they haven't really encounter a cross-linking patient or haven't for some reason had the need to refer for cross-linking. And if those doctors tell me, hey, you know, is it okay if I wait for some progression before now I'm really sure when the only way for some reason that I'm sure that this person has keratoconus is to see a little bit of progression, hopefully not major, and that would then I will refer for cross-linking, and that would be sort of one camp. And then the sort of more aggressive camp that if you look at that global paper that consensus paper that we talked about, where there's no need for documented progression as long as there's a risk of progression, such as what you mentioned, family history, one eye already progressing, which means that the other eye is very, very likely to progress in a young patient. That establishes the perceived risk of progression. That constitutes a reason to have that discussion with your patient to say, well, listen, there is a treatment called cross-linking. This is what it will do for you. That's not a way for you to lose your vision and go through the hardship of me not being able to provide the best optical rehabilitation method for you throughout the next 5 to 10 years of you losing your vision. That's just go ahead and offer cross-linking and then monitor you for the long term. So that's those are the two camps. And interestingly, I feel like the co-management ODs and the MDs refer patients into our site. I think the more that they see patients back to them where there's really no complication, the more they become the very progressive camp. So I don't think that there's anything wrong with taking the conservative approach if just for some reason you haven't seen a ton of patient who has been cross-linked. But I think I would say if you want to be in the camp, then please do monitor your patient very closely so they don't get to the point where maybe the cornea is too thin to be cross-linked.
Got it. Hey, Chris, how about the next question?
Got another one here, kind of a big question. Where do we stand with epi-on? Does epi-off have a better outcome?
That is a big question.
That's the next webinar, I think. We're going to have to, there is no next webinar, but that's a huge question. I'll say this, and just to keep it short and sweet, because I'm sure there's a lot of other questions. Number one, the FDA approval was for epi-off. Clark came from an epi-off site. I came from an epi-on site. I'm a pretty big fan of epi-on. I think, where do we stand with it? It's not approved by the Food and Drug Administration. I don't think we're likely to get approval for epi-on because it takes a lot of money, a lot of time, and a lot of effort. And we already have the approval, and it's really a more passive treatment. Like I was saying before, the reasons why I'm for epi-on treatments is because it's less traumatic to the cornea, and in a pediatric population, it's probably easier for the kid. It's easier to get them back to school, and you have less risk of infection and haze. But there's been clear, definitive information out there that Clark can probably give you days' worth of information that we get a deeper saturation of the riboflavin and probably a more effective treatment in terms of how much actual cross-linking takes place. And as our biomechanical tools of the cornea get better with time, although there are some great ones like the Reichert unit, and Oculus actually has something called the Corvus device that we'll be seeing on the market pretty soon. I think we'll be able to understand this a whole lot better. But epi-off is approved, epi-on is not. I say this at every lecture, for a progressive keratoconus, any cross-linking is better than no cross-linking.
I would agree with that. Any cross-linking is better than no cross-linking.
Next question.
Okay. This question, how is progression defined?
You want to hit this one, Clark?
Sure. And again, just we're adopting to the newest definition from this paper. That obviously doesn't mean that in the future, if we have better understanding in terms of biomechanics, such as the Corvus units that Andrew had just mentioned, obviously it is a working definition. But currently, the one that we use clinically is when you're looking at progression, you need 2 out of the 3 of the following criteria, and that is you need to have progressive steepening of the anterior cornea or anterior contour, and also progressive steepening of the posterior cornea, as well as progressive changes in the rate of the pachymetric distribution being more and more abnormal. So you need 2 out of the 3 criteria to be able to document progression.
How about we'll do one more question because it is 9:15 already, and I know that we have to call it quits at some point.
Yeah.
So, how many questions do you have left?
Absolutely. Let's see. I have 2 more questions left on the list. If you want to take both of them.
Let's knock out both of them.
Yeah, this is a question. Why not do epi-on, even though not approved for the better eye? No risk for infections and no pain.
Do you want to take this one? Or
sure. It's something that I've done before in our center. That we, again, I think ultimately the most important thing. There's a lot of factors to take into consideration, right? Number one is the younger patient that you have that progresses quicker. It's really interesting because I would love to get a pediatric individual with keratoconus through the process quicker, easier, and back in business. Because remember, we're talking about keratoconus patients. These patients, their glasses prescription, it's very normal to have a -9, -4.5, axis 130, best corrected 20/25 in one eye, and a -2, -9, axis 160 in the other eye. So putting these patients into glasses is not a fun thing. You want to get them back to their contacts as rapidly as possible. And then number two, you know, in an epi-off situation, their glasses aren't even going to work anyway for quite some time because that epithelium has to remodel, and we all know that epithelial remodeling of a you know, of a keratoconus cornea is slower than a non-keratoconus cornea. That said, for the pediatric patients that are progressing at a quicker rate, you want to get the maximum amount of cross-linking possible to halt the progression as rapidly as possible. So, you know, you're less likely to achieve that in an epi-on procedure, and you have a higher likelihood of having to go back and do more cross-linking on that patient, where you may be able to get more cross-linking in an epi-off environment, but for the activities of daily living of the patient, yet you know you have to take that into consideration as well. So it's a juggle. It's not an easy answer. I don't know how you feel about it, Clark. I know in your center you only did epi-off. We had the opportunity to do both in ours. Well, at least when you were part of the study, you were doing epi-off. I don't know.
No, we did both epi-off and epi-on.
Okay. All right. Well, I think it's just a tough challenge. But in my personal opinion, if it's my kid, you know, I would not hesitate to do an epi-on procedure and then go back and do more epi-on if I needed it, just because of the they may need more treatment. So the answer is
well, right. So if I may just throw my 2 cents
Sure.
in, I actually agree. I agree with the logic of the question, to be very honest, and that is, for one, potentially, you know, again, let's go back to the concept of perceived risk of progression from that paper, right? So of course, everybody, you can have your own, we may eventually have our own subjective algorithm in saying, well, what is risk of progression, and how do I capture that in this moment when the patient's in front of me? So that's obviously not the point of this talk, but let's just go back to that idea of, correct, you don't need, just as there are surgeons or study sites that will treat without need to document progression. You know, if you, on the flip side, have somebody come in with 20/20, and maybe, like, you know, it happens to be one of those patients that MD had just said, well, the better eye is not, you know, not yet progressing, it's the worst eye is progressing, and family history, you know, both parents, let's just say, both have keratoconus, you know, obviously that constitutes, you know, a very legitimate risk of progression, both genetically and also can be documented in one eye clinically. So in that case, is there anything wrong using, say, epi-off treatment for that eye that's already progressing if the patient should want to, or if you believe that that is the better way to stop an aggressive form of a keratoconus progression? Absolutely, I think that's fine. But let's go back to the other eye. Yes, there's perceived risk of progression. Therefore, this 20/20 eye deserves cross-linking. But what if you then request to have epi-on cross-linking, assuming a site can offer both, one, you know, FDA-approved, one non-FDA approved off-label treatment? I actually agree with that. I think that is what we look for. It's about choosing, it's about customizing your treatment.
Clark?
Yeah.
Clark? I just have to jump off the call. I'm going to have to call you. I'm going to jump off the call right now. I just got to take care of something with the family.
Not a problem. I can take care of the next question. So, you know, I want to say I agree with that because, you know, there's nothing wrong with then the other eye that is not heavily progressed. And if you, for some reason, are concerned of whatever mild complication, whether it's just a little bit of, you know, longer recovery road from epi-on, and you want to refer the patient for, or from epi-off, I'm sorry, longer recovery from epi-off, and you want to refer patient for epi-on. I completely agree with that logic. I don't think you have to use the same treatment on every patient. I also don't think that if a site has more than one treatment available, that you absolutely don't have to require the patient to have only one type of treatment on both eyes. So I actually think that's a great question, and I agree with that logic.
All right, thanks, Dr. Chang. So I've got this last one here, and this is I think a good question. Best corrected visual acuity could take months after cross-linking epi-off. How will you deal with that in terms of explaining it to the patients?
Well, again, it actually, for majority of our keratoconus patients who, it's maybe now we're going to be different because we have better instrumentations to diagnose them early. But for most of your keratoconus patients who are already who cannot achieve best corrective vision without their contact lenses, we're not talking about someone who's 20/20 or 20/25 or even 20/30 most of the time. They have loss of vision where they're not going to have trouble, most of them, if they cannot tolerate contact lenses, we have a lot of patients who just wear contact lens on one side and rely on one eye for majority of the day or, whatever working hour they have. So that's where we really liked our monocular treatment because, number one, epi-off really doesn't, if compared to now wearing contact lenses versus, let's say, 6 weeks or 4 or 6 weeks to stay away from wearing contact lenses and then getting refitted after epithelial off cross-linking, that's not a stretch for most keratoconus patients who cannot tolerate their contact lenses, number one. Number two, let's go to the flip side with the epi-on. It is true that I do fit patients early on or earlier with epi-on cross-linking, which is what everybody sort of hint at, and the fact that there's less recovery time, which is true. But I mean, if they're not going to magically become 20/20 just because you cross-link the patient, so and also I do want to point out that there have been documented cases of epithelium sloughing off after epi-on because you have to disrupt the epithelial junction in order for the riboflavin to get in with our current technology. They're working on riboflavin technology that may be different. So, don't think that epithelium on is going to be pain-free for most of your patients, because I don't want you to have even one patient coming back to tell you that they have a lot of pain. But so that line is not as well-defined as most people think in terms of the recovery road. I mean, you're looking at a difference of maybe 2 to 3 weeks earlier to fit or refract patient after epithelium on versus epithelium off. So really, honestly, it's not different of a time period you're looking at in my approach.
Okay. Thanks, Dr. Chang, for the great presentations and for sticking around to answer questions. Really appreciate that. I'll go ahead and close the webinar now, and I have some information on the screen for those of you out there interested in watching past lectures that Oculus has put on. You can watch those at our website at www.oculususa.com. We have a separate website where we have some live lectures that are broadcast. That is www.oculustv.com. And then for current customers, if you have any service-related questions, you can contact us here via email or at the 1-800 number you see on the screen. For any product questions or for product demonstrations, you can contact our sales department, and I have the email here, sales@oculususa.com, or the 1-800 number listed on the screen. So again, thank you, Dr. Chang. I know Dr. Morgenstern has left, but I'll say thank you to him anyway, and everybody from IK, especially the doctors that have presented throughout this webcast series. So and thank you all for joining us tonight. So have a good night.
Have a good night, everyone.